Good evening, class. You are welcome to GNS 311 Reproductive Health. We have discussed on what reproductive health is all about, what brought about reproductive health, the components of reproductive health, in which safe motherhood is the first component of reproductive health. Today, we are going to take the first component on safe motherhood, which is prenatal care. Prenatal care, by definition, you can say prenatal care or antenatal care. Prenatal care, by definition, refers to care given to a pregnant woman from the time conception is confirmed until the beginning of labor. During this period, healthcare services that we provide for the women, which include information, counseling services, and education, are given to women during the pregnancy. And the aim of this prenatal care is to monitor the progress of pregnancy in order to support maternal health, normal fetal development. It is essential that the midwife critically evaluate the physical, psychological, social effects of pregnancy on the woman and her family. As I've said, the aim is to, one, develop a partnership with the mother and to counsel the expectant mother and her family. Two, to deliver a live, full-time, healthy baby with no injury to the mother and the baby. Three, to provide holistic approach to the woman's care that meets her individual needs. Four, to prepare the woman for successful breastfeeding, normal preparium, and care of the baby. Five, to dictate early high-risk conditions arising during pregnancy and appropriate referring women within the multidisciplinary team. Six, to manage high-risk conditions appropriately by choosing the care that is appropriate for our own needs. Seven, to prevent life-threatening conditions. Eight, to promote physical, mental, and social health of the mother through information, education, and communication, IEC. 9, to facilitate the woman and her family in the care. 10, to immunize mother against tetanus toxoid in order to pass immunity to her baby. 11, to equip the mother with the knowledge and skills that will help her take decisions on related reproductive issues such as family planning, self-breast examination, pap smear screening for prevention of breast and cervical cancers, respectively. 12, to help mother to plan for delivery, that is, birth preparedness, and then to prepare the mother psychologically towards labor. We've been talking of prenatal antenatal care. We are going to talk on focus antenatal, that is, whose models of focus antenatal. And what do we mean by focus antenatal? Focus antenatal is antenatal care that is given. It is a qualitative care given to a pregnant woman by a trained health provider to promote the health and survival of the mother and child. It is an approach to antenatal care that emphasizes or it is evidence-based, goal-directed action, and family-centered care. It is based on quality care rather than quantity of visits, and this is provided by the skill provider. In focus antenatals, it has minimum of 4 antenatal clinic visits, and each of these visits has a specific items for the client's assessment, education, and care to ensure the prevention of or early detection and prompt management of complications. The advantage of focus antenatal is that it is goal-oriented and directed care. It is evidence-based care. It is a qualitative rather than quantitative visit. It is family-centered care. It is given by skilled attendants. The goal of the focus antenatal is to promote maternal and newborn health and survival through its 4 components of care. That is, in focus antenatal, it has 4 components, and we are going to be discussing each of these components one after the other. The first component of focus antenatal is early detection and treatment of complications in pregnancies, which include induced hypertension, malaria, anemia, etc. 2. Preventions of complications and diseases by the use of IPT and ITN. IPT will mean intermittent preventive treatment, while INT means insecticide treated nets. So in this, you know that we are talking of preventions of complications of malaria. In the use of IPT, we use a drug known as SP, which stands for sulfadoxine pyrimethamine, and this is given 3 tablets, 2 doses throughout pregnancy, and for HIV mothers, you give 3 doses, you increase the dose by 1. And then the use of insecticide treated nets. This is for malaria prevention. Then the third component has to do with birth preparedness and complication readiness. This has to do with arrangement in advance with skilled birth healthcare provider, how to get transport when labor starts, blood if it's needed, finances she will use during labor, who is the decision maker at home. This is to avoid some of the delays that prevent women from coming to the hospital early until complications arrive. Items needed ready for delivery. And the fourth component has to do with health promotions. And when we are talking of health promotion, we are talking of health education and counseling. And during pregnancy, we can counsel on the following things: individual needs, most prevalent health issues, in the environment like malaria, as we have discussed the prevention. Then we have nutrition, rest and sleep, family planning, exclusive breastfeeding. These are some of the things we educate the woman on during an antenatal clinic. And what are the reasons for focus antenatal clinic? The reason for focus antenatal is to allow pregnant women at risk of developing complications to detect them early and take appropriate action. Two, more attention is given to individual, especially at risk group. Approach to the care is no longer considered effective in detecting the routine antenatal care is not longer effective in detecting which women have problems. So that is why emphasis now is on focus antenatal, individualized care. Three, many pregnant women in Nigeria do not have do not appreciate the importance and the benefit of antenatal care, attend antenatal care just to obtain registration card and in case of unexpected emergency. Stay away from health facility because of poor providers' attitude, unfriendly policies, e.g. compulsory blood donations for antenatal services, inability to pay services, inaccessibility and non-availability of services as skilled attendants. Antenatal risk increases the likelihood that a skilled attendant must be present at birth, according to WHO and UNICEF. In many countries, antenatal care is the only time woman has contact with healthcare system. Therefore, antenatal care is a unique opportunity and platform for providing a variety of health services. Objectives of focus antenatal is to promote mother and newborn health, to maintain good physical and social mental health for the woman, to ensure delivery of a mature life healthy baby, to prevent congenital abnormalities, to prepare the woman for labor, lactation and subsequent care of her baby, to detect early and treat appropriately high risk conditions. Who are the personnel that are needed for this focus antenatal? We have trained midwives, trained CHOOS, trained doctors and obstetricians, etc. As I've said, we have four components of focus antenatals that we are going to be discussing one after the other. The first one is early detection and treatment of problems and complications. This is the number one goal of focus antenatals. The aim is to detect early and treat conditions like malaria. And you can do this by history taking, physical examination for fever, accompanying signs and symptoms, then rapid diagnostic tests, and this is coupled with the region that the woman live, and you teach, you classify the malaria either complicated or uncomplicated and then treat appropriately. Then severe anemia. This can be detected early through physical examination, hemoglobin testing, etc. 3. Pre-eclampsia and eclampsia. This can be detected through measurement of blood pressure, urine testing, and physical examination. HIV. This can be done through voluntary counseling and testing. Sexually transmitted infection including HIV testing. Then TB screening for tuberculosis. Prevention of disease and complication. That is the number 2 goal. Aim at preventing the following: malaria through the use of intermittent preventive treatment (IPT) by the use of sulfadoxine pyrimethamine (SP) known as Fancida. We give 3 tablets using DOT, and the full meaning of DOT is direct observation treatment strategy. The first dose of 3 tablets is given after quickening, that is from 16 weeks. The second dose of tablets at least 4 weeks after the first dose up till that is 6 weeks. Then the use of insecticide treated nets (ITN). 2. Tetanus toxoid to prevent maternal and neonatal tetanus by giving the mother tetanus toxoid during pregnancy. Then nutrition, educating the woman on the type of nutrition to eat during pregnancy, the ones to avoid during pregnancy are all emphasized. Then iron and folate supplementation to prevent anemia. Specific intervention as appropriate, e.g. vitamin A and multivitamin supplements. Antiemetic drugs are also given. Example, mebendazole for presumptive treatment of worm. All this effort is to prevent anemia. The third component of focus antenatal is aimed at birth and readiness in case of complication. Birth preparedness and complication readiness. The purpose of birth preparedness is 1. To develop exact plan for normal birth of a baby. 2. To establish a financial plan scheme to use as the need arise. 3. To ensure that there is adequate funds, easy transportation, and appropriate facility without delay in case of an emergency. The woman and her family, in collaboration with skilled attendants, that is the midwife, view this arrangement at every visit. Complications occur in about 15 to 40% of all pregnancies, so the woman and her families must be prepared for birth and eventually in case of an emergency. Time wasted in an emergency may have great consequences and may lead to maternal death. Important components of birth preparedness includes early booking, informing clients on signs and symptoms of pregnancy complications, saving 12 birth and delivery by by the pregnant woman and the husband. Procurement of materials needed during pregnancy and birth. Identification of the family that will stay at home with other children and with the pregnant woman in the hospital. Identification of members of the community that will provide transportation when labor starts. Identifying viable communication means with the hospital and vice versa. Health information on nutrition, hygiene during pregnancy, preparation towards exclusive breastfeeding or artificial milk, educate women on the importance of antepartum and postpartum exercises, antenatal tour of the delivery room by the pregnant woman before delivery. In complication readiness, it is said that 15 to 40% of all pregnant women develop a life-threatening complication requiring emergency obstetric care. The following are the processes of complication readiness. 1. Identifying decision makers. The person to take decisions, action during an emergency should be identified, e.g., is it the husband, any member of the relative, or is it the in-laws? All these should be identified on time. Then 2, identify appropriate facility for delivery within 24-hour services for emergency obstetric care. 3, identify a member of the family or community that will provide emergency transportation in case complications arise. Provision of emergency funds from patient's husband, family members, or even the community. Making arrangements for blood transfusion. Then skilled attendants must be ready to manage complications effectively until client reaches her point of referral. Note: the survival of mother and baby is shared responsibility of the caregiver, the woman herself and her family, the policymakers, members of the communities. Therefore, timely and effective intervention saves life. The fourth component of focus antenatal, which is health promotion, and this has to do with health education, which is the goal number 4. Inform and educate women with health messages and counseling appropriately to individual needs and concern, gestational age, most prevalent health issues. This is by supporting the woman in making decisions and solving actual and anticipated problems. Involve partners and family in supporting and adopting healthy practices. Health education topics that can be addressed include prevention of malaria through IPT, ITN, other preventive methods like environment free of breathing sites for mosquito and personal protections. Education on diet. advice on adequate diet, prevention and treatment of anemia. Then 3, care of common discomfort. Use only prescribed drugs. Avoid potentially harmful substances, e.g. herbs, unprescribed drugs. Advice on tobacco and cigarette smoking. Effect of alcohol intake and tobacco intake, especially during pregnancy. Infection prevention hygiene. This includes hand washing before preparing, eating food, and drinking. Hygiene. This includes both personal and environmental hygiene, e.g. use of safe drinking water, handling and storing food safety, practice good dental hygiene. Then we will also advise or educate on rest and sleep and activities. Third client to 1. Decrease the amount of heavy load and increase rest time. Avoid lying on the back, especially in late pregnancy, to prevent decreased blood supply to the placenta site. Advised to lie on the side. Maintain good body posture to avoid overextraction. Advice on sexual relationship and safe sex. This is to reassure clients that sexual intercourse will not harm the fetus. Have sexual relationship with one partner who is free from HIV and other STIs, or practice abstinence if desirable. For those patients that are at risk of STIs and HIV, use condom correctly and consistently. Then also educate them on importance of delivery by the skilled attendant, birth and delivery preparedness, early and exclusive breastfeeding, immunizations, HIV/AIDS prevention, care, and the role of voluntary counseling and testing, and MTCT, maternal to child transmission. Then also educate on prevention of endemic disease deficiencies, e.g. hookworm infestation, postpartum child spacing, that is family planning, postpartum care of herself and the baby. Educate on danger signs in pregnancy during labor, e.g. vaginal bleeding, difficulty in breathing, fever, severe abdominal pain, severe headache, blurry vision, convulsions, loss of consciousness, labor pain before 37 weeks of gestation, that is preterm labor. Also educate on prevention of complications of pregnancy and childbirth. Education on early detection and treatment of existing complications and problems such as malaria, preeclampsia, HIV, through VCT, voluntary counseling and testing, and prevention of MTCT, maternal to child transmission, STIs infections, including syphilis testings and tuberculosis screening. Then care from skilled attendant and continuous care is also important. Who is a skilled birth attendant? A skilled birth attendant is somebody that has formal training and experience, has knowledge and skills and qualifications to deliver safe, have effective maternal and newborn care, then education also is on birth planning, preparedness for complication, readiness. The purpose is to develop a birth plan, the exact birth plan for a normal birth of a baby, to establish a financial plan and scheme in case of any emergency. To achieve this arrangement should be made in advance by the woman and her family, which will help the skilled attendant. This is also reviewed and revisited at every visit. Advantage of birth preparedness is to ensure timely and appropriate care. 2. Choice for facility or place of birth. 3. Appropriate site for emergencies and how to get there. Then recognition and significance. How to make antenatal service more friendly. 1. This can be done by avoiding rigidity of procedure. Avoid compulsory shaving of the pubic hair, giving routine enemas, routine episiotomies, etc. When they come to deliver, then allow flexibility in labor and delivery. This includes the beddings, ambulation, oral fluids, delivery positions, return of placenta to the patient. Then allow social support in labor and in postpartum period. Respect harmless traditional practices in the community. 2. Clients' rights and providers' needs must be respected at all times. These clients' rights include right to information, dignity, comfort, privacy, confidentiality, right to access services, right to choose, adapting, switching, or discontinuing method, right to safety, right to continuity, and right to express about the quality of service. 3. Recognize and meet providers' needs. Respect and recognition, knowledge and skill updates, adequate infrastructures and supplies, standard and guidelines, encouragement and feedbacks, support supervision, and self-expression. What are the roles of men in antenatal care? 1. Encourage and support women morally, psychologically throughout pregnancy. 2. Provide financial support throughout pregnancy. Encourage women to attend antenatal clinic and subsequent visits. Encourage the women to take their anti-malaria (SP), Hemathermics, good adequate diet, and assist women in their birth plan. 5. Help women in birth plan and complication readiness. Ensure that the woman sleeps under intestinal treated nets by buying the net or retreating it when necessary. Accompany their wives to the hospital when sick, especially during labor or when the need arises. Prevention of transmission of sexually transmitted disease by being faithful or use condom correctly and consistently. That's the role of the men during antenatal care. We are going to be discussing the timing and schedule visit for focused antenatal care and the routine antenatal care. The Nigerian National Policy Guideline for Reproductive Health recommend a minimum of 4 antenatal visits. The rationale is to reduce the number of antenatal visits to minimum to encourage the client to keep appointments and improve health-seeking attitudes, and does not compromise with quality of care. The 4 visits of antenatal care have a focus on critical and important stages of pregnancy. Schedule for the focused antenatal. Visits should be 4 times throughout pregnancy, unless need be, and the visits are scheduled as follows. The first visit should be before or within 16 weeks of when the woman thinks she is pregnant. The second visit should be between 20 to 24 weeks, or at least once in the second trimester of pregnancy. The third visit from 28 to 38 weeks of pregnancy, and the fourth visit is from 36 weeks or later, or until the woman delivers. Note that unlisted visits are welcome when the client has concern or experiences a complication with focused antenatal. This visit may be made when 1. Complications occurs, 2. Follow-up or referral is needed, 3. When woman wants to see her provider, or when the provider changes frequency of visit based on her finding, that is from the history, examination and testing, or based on the local policy of the health institution. But before the focused antenatal, the routine visit we used to have is as follows. The number of visits varies. Below is the recommended schedule for the visit. From 1st to 28th week of pregnancy, the woman attends antenatal clinics every 4 weeks interval. As soon as she reaches 28 weeks to 36 weeks, the routine changes from every 4 weeks to 2 weeks visit. Every 2 weeks she attends antenatal clinic. And from 36 weeks to time or delivery, the woman will attend antenatal clinic weekly until she delivers. This becomes cumbersome, ritualistic, and that is why the whole models of focused antenatal was scheduled to be goal-oriented, based on individual needs, time-friendly, evidence on quality, not quantity of care. When you calculate this scheduled visit in the routine antenatal care, you see that the woman throughout pregnancy can have up to 10, 12, 14 visits before her delivery. So let's look at the differences between routine antenatal and focused antenatal care. In routine antenatal, it is routine and ritualistic, while in focused antenatal, it is evidence-based. In routine antenatal, frequent care 12 or more times, while in focused antenatal, only 4 visits. Then in routine antenatal, does not emphasize individual client's needs, while in focused antenatal, it emphasizes on individual client's needs. In routine antenatal, it is burdensome to women, while in focused antenatal, it fits well to women's schedule. In routine antenatal, it is costly to the health system, while focused antenatal is not costly to the health system. Routine antenatal is cumbersome, routine measurement and examinations, while in focused antenatal, not cumbersome. The routine measurement is not cumbersome because there is no or fewer measurements are taken, not routine measurements. In routine antenatal, care is based on risk assessment, while in focused antenatal, care is based on individual's need. In routine antenatal, care given may not be by a skilled provider, while in focused antenatal, care should be given by a skilled provider. Note, in the year 2016, WHO brought another guideline to follow in focused antenatal, and this guideline is based on 3 semesters of pregnancy, and this visit could be up to 8 visits throughout pregnancy. So using the WHO's models of focused antenatal, in the first trimester, the first contact is when the woman thinks she's pregnant up to 12 weeks. In the second trimester, the second contact and the third contact can occur at 20 weeks. The third one can occur at 26 weeks, while in the third trimester, we have the fourth, fifth, sixth, and seventh and eighth contact. The fourth at 30, the fifth contact at 34, the sixth contact at 36, the seventh contact at 38, while the eighth contact is at 40. Then before the woman turns for delivery. Using of antenatal risk form, what we call ARAF form. I don't know, Mister. It's a record period, so I don't know if I don't know how they can see this. This is a form I want to show them. Is it possible? Okay. This is what we call ARAF form, Interpartum Risk Assessment Intervention Form. This is what we call Interpartum Risk Assessment Form, known as ARAF form. It is a tool, as you can see it in a graphic form. used by the midwife to assess pregnancy progress and identify high risk conditions. It is specially designed to monitor fetal growth and identify pregnancy-induced hypertension and anemia. The form provides a place to write all information needed for the woman during delivery, include her first history, complete physical examination findings, treatment, and advice. Therefore, when the woman returns to antenatal care, it affords the midwife the opportunity to reel and remind her of the findings of the previous visit. This form is used by a skilled attendant through a skill of ask and listen, look and feel, identify problems and needs, and then taking appropriate actions. Problem-solving method. The other form is divided into two parts, which are the history part. In the history part is done by asking, listening, and filling the biodata of the client, the medical and surgical history, previous obstetric history, menstrual history, while the physical examination is the second part to be recorded. The physical findings of examination throughout her pregnancy. The findings include fundal estimation in centimeters to decide the week of gestation by date, the column for blood pressure, fetal heart rate, albuminuria, hemoglobin, treatment, signs and symptoms, patient's weight, examiner's signature, date column. The information will help the midwife identify problems of pregnancy-induced hypertension, eclampsia, anemia, other problems of pregnancy or high-risk patients. The other form can be used to support or supplement the current antenatal card used in the hospital and clinics. The charges are done on the lines. The normal hemoglobin level by World Health Organization for the non-pregnant women is 12 grams, and for the pregnant women is 10 grams. So if a pregnant woman comes to you and you take her hemoglobin level, you test it, and it's less than 10 grams, you should take action. The woman, depending on the level, is becoming anemic. Having known the level of anemia, you should treat appropriately. This case study I have is just an hypothetical case, also learn how to fill the other form to detect problems like anemia, pregnancy-induced hypertension, and then treat or manage accordingly. So using this hypothetical, fill in these findings on the risk assessment form. Mrs. YA is 18 weeks pregnant today. She came for 4 antenatal visits, and you gave her iron, folic acid, vitamin C at each visit. At 4 visits, the first visit, her height was 160 centimeters, blood pressure was 160, her weight was 62, hemoglobin was 10.2 grams, weeks of gestation is 18 weeks, signs and symptoms none. By size, when you took the estimation, it was 18 centimeters. At second week, her blood pressure was 110/70, weight 64, hemoglobin 8.5 gram, week of gestation 24 weeks. Signs and symptoms: she looks tired, eyelid very pale. Then by size 25 26 centimeter. Third visit, her blood pressure is 120/70, weight 65, week of gestation 32. Signs and symptoms: still very tired, eyelid very pale, not taking medication regularly. Then by size, the week of gestation is 35 centimeter. Fourth visit, her blood pressure is 120/80, weight 67, hemoglobin 9.5 grams, week of gestation 35 weeks. Signs and symptoms: complaints of constipation from iron tablets, less tired, eyelid still very pale. By size is 36 centimeter. If you are opportune to fill this hypothetical case on the ARA form, we will be able to detect what is happening to the woman early. That you can see the blood pressure is getting higher from 160, which is the baseline, to 120/80 per mercury. You can see there is signs of preeclampsia. If per her complaint, there's other signs that indicate that she's having preeclampsia, we treat early so that she will not have eclampsia, which is the fitting that occur as a result of preeclampsia. We'll be able to avoid that. And you can see, according to WHO's definition, a woman that has less than 10 grams of hemoglobin, automatically she's anemic. Then you have to treat for anemia, give her more hematemic drugs. If the anemic, you should treat the anemia before the woman gets into labor, because this can predispose this woman to other complications like postpartum hemorrhage. You'll be surprised that why is it that a woman with anemia is having postpartum hemorrhage? As per the definition of postpartum hemorrhage, that a woman that loses more than 500 ml of blood or any amount that will deteriorate her condition. And if a woman is already having anemia before she delivers, with little loss of blood, it can lead to deterioration of her body. So that's why we should treat anemia before the woman falls into labor. That brings us to the end of prenatal care, focus antenatal. The component of focus antenatal, which include birth preparedness, complication readiness, planning for a normal birth, early detection and prompt treatment, and then health promotion. And as a midwife, as a skilled midwife, you should be flexible, more friendly to your patient, encourage your patients to come to antenatal care and also to deliver in the hospital. If the patient cannot deliver in the hospital and she has no any risk condition, you can follow her, prepare, be more friendly to your patients. That's why patients are running away from us, from the hospital. Plan together. Okay, if labor starts, who is around to conduct? You two can even go and conduct her. If environment is favorable for home delivery, you take her delivery at home. You are allowed to adapt to any position that suits her. You don't force her to be in a position when she wants to deliver. respectful maternity care. Who did she want to be a bad companion when she's coming to the hospital? All arrangements should be made. Plan together with the patient, husband, and relative. This will help us to achieve the first and most important component of safe motherhood, aimed at reduction of maternal and neonatal mortality. Thank you.